Yeah, okay, good. Yeah, great. Yeah, so Sandeep
Right.
will do it actually because, yeah. So Sandeep, I think you can moderate this and start whenever.
Yes, sir. Almost like 27 participants are there already.
Okay.
So we can start, I think, like almost like 5:30, 5:33 now.
Okay, and just to be clear, who has the poll for the question after the lecture? Do you have it, Sandeep?
Yes, I have the polls ready.
Perfect, perfect, perfect.
So just one of the nurse, just a few things she wanted to talk. Quincy,
Sir, audio is enough, sir?
Quincy, yes, we can hear you.
Yeah. Good evening, sir.
Good evening.
Good evening.
Good evening to all. I am.
Thank you.
Oh,
Yeah,
hello.
yes. I am
Hello.
one of the senior staff in BMT. I have been here in BMT unit for last 1.5 year. So today, on behalf of all the APP trainees, I would like to take this time to thank you all for all your concern, effort, and support that you have put in to this APP course. On behalf of the team, I would like to thank you for giving us this opportunity to widen our knowledge and help us in our careers. We have heard a lot and learned about you for your passion, for the growth of the nurse that you have from Sir Sandeep. Thank you for all the efforts that you have put in to bring us to this platform. Thank you once again for having a big heart for the nurses in India, for drawing us out of our best in our life. Thank you. Thank you once and all. Thank you for all the trainers too. Thank you.
Thank you very much. That's nice words. Nice things to say.
Yes, Quincy, thank you very much.
Welcome, sir.
Thank you. And ready for working because we are there for you, but you have to work a lot. So we will be there in order to help you.
Yeah. Yes, ma'am. We will do our best.
Okay.
All right, shall we start?
Yes, sir.
All right, all right. So welcome everybody to the first lecture of the preparatory phase for the impact course. And today is just the basic about the transplant, the bone marrow transplant lecture. So just a disclaimer, every slide on this presentation is a lecture by itself. So we're gonna start, but if there is anything or any question at any point, just stop me and ask. All right, so the outline for the lecture today is just gonna cover the basics of hematopoietic stem cell transplantation. So we'll start with definition and history. We'll talk about types of transplant. We'll talk about HLA typing. Just the basic to 1 or 2 slides, and then we'll talk about the roadmap for transplant, and then some of the toxicities, and then the basic supportive care principles and the outcomes. So what is transplant? Transplant is a process of replacing bone marrow stem cells with new hematopoietic stem cells. The definition of the stem cells are the cells that are capable of both renew the cell itself, so self-renewal, and generation of specialized other cells. And I have a cartoon in a minute that will show that. So this is just a brief history on when the transplant started and the timeline for it. So as we all know, the transplant started to treat acute lymphocytic leukemia. It started in 1959, and then it progressed through the years till now, where now we have used DLI, which is donor lymphocyte infusion, whether for leukemia or to treat infection like CMV. And then in the blue here, we have the generation of what we call the CAR T therapy, which stands for chimeric antibody Sorry, it's early on. My voice is early here in the US, and my voice is still waking up, I think. So this here is just the generation of the CAR T. This slide just showed the progression in the United States of the transplant, whether it's autologous or allogenic. If you can see, there is a blip here, increase of the allogenic transplant, and this is where we saw that autologous transplant will treat breast cancer, which turned out not to be true. But throughout the year, the transplant is growing and it becoming more available and more safe. This here just showed how many transplant in the US, and this is from the CIPMTR data, and what is the source. Just to show that throughout the year here in the US, from the 2000 till 2017, there is around 1,000 to 1,200 transplant a year for children less than 18 years of age. This is just another way of sharing the same data. I'm not going to go through it, but it's just showing that transplant is a field that has grown and it's continuing to grow. So this is here, what is the overview of transplant? When I said the stem cell transplant, they are the cells that up in the top here where they can renew themselves, so they can divide and become back themselves. So this is why you see this loop. And then they can also divide to produce two things in the pathway. The first things on the right, there is a common lymphoid progenitor cells, and those can further subdivide to natural killer cells or NK cells, or what we call a small lymphocyte. And this small lymphocyte can either be B cells or T cells. B cells can mature and become plasma cells. Here on the right, these cells, the function of these cells is to fight infection. And then if you go up to the stem cells, again, they can divide to produce common myeloid or common lymphoid, or they can renew themselves. So for the common myeloid, they can produce the megakaryocyte, which further give you the thrombocyte or platelets. The function of those is to stop the bleeding. It can give the erythrocytes. The function of the erythrocyte or the hemoglobin is to carry the oxygen. It can give you the mast cells, or what we call the myeloblast. The myeloblast, further they can subdivide it to the basophil, neutrophil, eosinophil, and monocyte, and then the macrophage. So if you look at a CBC from one of your patients, what you see is the number of the platelets, the numbers of, or the concentration of the hemoglobin and the number of the hemoglobin. You can look at the subdivision of the basophils or the myeloblast, which is the basophil, neutrophil, eosinophil, monocytes. You can look at the total lymphocyte count or number. And further, you can look at the NK cells, and you can look further to B cells and T cells, and can further do what we call a lymphocyte function or number or count to look at how many T cells and what is the overall number of them. So what you see in a normal or on a CBC for a patient, it's all coming from these stem cells. So transplant is transplanting this cell to generate all of these down here. So what is the type of transplant? So the first type of transplant is what we call autologous transplant. Autologous transplant, when we take cells from the patient himself, give him therapy, and then give him the stem cell back. So this is the patient's own stem cells. Allogenic transplant, it's coming from somebody else. It's coming from a donor. And this donor can either be related or alternative donor. What is the alternative donors? They are unrelated bone marrow donor, umbilical cord, or peripheral blood. And then there is a third type of transplant, what you call a synergistic. And this is a transplant when we take the stem cells from identical twin siblings. We don't do that kind of transplant that much. So your two main big transplant thing is allogenic and autologous. You have to remember this for the question after the lecture. So what is the difference between bone marrow transplant and solid organ transplant? Solid organ transplant, like kidney transplant, liver transplant, lung transplant, or heart transplant. So if you look at the immune cells in the graft meaning that the organ you took to give the patient, whether it's a bone marrow or a solid organ. In the solid organ transplant, you have few immune cells. In the bone marrow transplant, you have many immune cells. Actually, you are transplanting the immune system. Is there any preparative regimen or conditioning regimen for solid organ transplant? The answer is no. For bone marrow transplant, you need to immune ablate the patient for the transplant to be successful. So you need to give either conditioning chemo or radiation therapy. What is the major clinical problem for the solid organ transplant? A rejection. For the bone marrow transplant is mainly graft versus host disease. Still rejection can happen, but nowadays it is becoming very rare. But the major big things is graft versus host disease. Immune suppression for solid organ transplant is a lifelong, meaning that the patient will take lifelong immune suppression when you give him a new kidney. For the bone marrow transplant, usually it's months. So naming for allogenic donor. So allogenic donor, it's either related or unrelated. Let's concentrate in related. If it is related, it is either match, mismatch, or haploidentical. If it is match, it's either match sibling or match non-sibling transplant. The mismatch, it's called MMRD and then haploidentical. Why I'm showing this? Because a lot in transplant world, you will see a lot of nomenclature or acronym. So MRD mean match related donor. MSD match sibling donor. MMRD match related donor. And then on the right side, when you have unrelated donor, so a related donor, it's either can be match or mismatch. If it is match, we call it MUD. So match unrelated donor, or mismatch MMUD. So this is just a general information. When you read the literature, you will see this nomenclature or terminology a lot in transplant, and this is where it comes from. So if you see we did a transplant from MSD, that's mean match sibling donor. So this is the basic of the autologous transplant. This is not allogenic transplant. Remember, autologous transplant, when you take the stem cells from the patient himself, give him preparative regimen, and then infuse the cells. So the first step is to collect the cell and store them. The second step is to prepare the patient by giving him myeloablation. It's either chemo or radiation, and then you reinfuse the stem cells back to the patient. So this is the basic of autologous transplant. Why do we do autologous transplant? We do it because sometimes the toxicity to the hematopoietic stem cell or system is the dose limiting factor for treatment with chemotherapy. So we take the stem cell or the stem cells are used to rescue the patient after high dose chemotherapy. So autologous transplant or auto transplant mean high dose therapy with a stem cell rescue. Why we do autologous transplant? We do it because for the most part, the disease are not in the bone marrow. The disease are solid tumor. What disease are those? For example, neuroblastoma, brain tumor, lymphoma, when it relapses, and other solid tumors. We also do it for gene therapy. This is the basic for allogenic hematopoietic stem cell transplant. So you have a donor, you collect the stem cell from the donor. There is several sources to collect this stem cell from, and we'll talk about it in a little bit. After that, you take the patient, you prepare the patient by chemo or radiation, and then you infuse the stem cell, the donor stem cells in the patient, and you wait for engraftment. This is just the very basics of allogenic transplant. So where do you get the stem cell? You either can get them from bone marrow, which is the top of this table, or from peripheral blood, or from umbilical cord. what is the pros and cons of each cell source. So availability, you can read it here, but what I want to stress about this table is the content of the T cells. So from the bone marrow, you have low T cells. In the peripheral blood, you have high T cells. In the umbilical cord, you have low immature T cells. And why I do mention this T cells, because T cells can cause two things in transplant. They can promote engraftment, meaning that when you have a high T cells, you have fast engraftment. When you have low T cells, engraftment is slower. So based on this, the peripheral stem cells, they engraft fastest, usually around day 11 to day 18. The bone marrow is next because they have lower immune cells and then, lower T cells. And then the umbilical cord is the slowest. Usually it takes about 28 days to engraft. And that is because they have low immature T cells. The second reason I mentioned the T cells is because of the risk of graft versus host disease. When you have more T cells, you have higher chance of developing graft versus host disease. So high T cells in the peripheral stem cells, meaning that your chance of getting graft versus host disease is high. And then in the bone marrow is lower than the peripheral, and umbilical cord is lost. Excuse me. And then there is other pros and cons is how you get them. Peripheral blood, you get it from peripheral vein. So usually it's like blood donation. Bone marrow, it's surgery. So you go to the OR, you get anesthesia. Umbilical cord, it's ready, it's stored after the baby is born, and so on. But the main thing, if you want to remember one thing from this slide, is the content of these T cells and the relationship between T cells and engraftment and T cells and graft versus host disease. Why do we do allogenic transplant? We do it either to eradicate unwanted hematopoietic stem cells, so such as leukemia, or to replace a single defective cell line, so like sickle cell or thalassemia, to replace the immune system. If you have a blastic anemia, immune system is overreacting and you want to replace it, or to provide source for the cell to make enzymes. And we'll talk about this a little bit. For the leukemia, you want the graft to kill the leukemia. So that's what we call graft versus leukemia effect. In here, this table will show you the things that I said. I said the goal for the bone marrow transplant, it's easier to eradicate unwanted cells, so eradicate hematopoietic hematological malignancy, so like CML, chronic myelocytic leukemia, AML, and ALL. And under each of these diseases, there is the indication for transplant, or to deliver a high dose chemotherapy, and this is autologous transplant, so auto transplant like lymphoma or solid tumor. We said you needed to replace a single cell line, so like RBC's disease, like sickle cell thalassemia, platelets disease, if you have what we call megakaryocytic thrombocytopenia, neutrophil disease like chronic granulomatous disease, lymphocyte diseases like SCID, Twist-Aldrich, and so on, or to replace the immune system like blastic anemia, MDS, or bone marrow failure, or to replace enzyme. This is from disease that have storage disease like Kraber or Gutcher or Herrera syndrome. There is other indication for transplant in the world. I'm not going to go through them, but this is some of them. So what is the roadmap for transplant? So this is the whole roadmap. First, finding a donor. Then you do pre-transplant testing for the recipient and the donor. Then you do the conditioning, chemotherapy, stem cell infusion, and count the days. So we'll go through each one of these in the next couple of minutes. So finding the HLA. What is the HLA? The HLA is the major histocompatibility protein identifying the cells are self. There is two big classes, class 1 and class 2. Class 1 recognize CD8 in the T cells. Class 2 recognize CD4 in the T cells. remember the major histocompatibility is the HLA. It's a human leukocyte antigen. Why it is very important? It is very important because if you have a donor T cells and donor other cells, so the donor immune system and the donor other cell like skin, liver, eye, name it, they usually live happily, and there is a way for this T cell to recognize the other donor cells. And in the patient or in the recipient also it have the same. But what happened when you take the donor T cell, the donor immune system, and you transplant it in another recipient? So you have the donor T cells or the donor immune cells transplanted in a patient, in another cell. So one of two things can happen. It's either the donor T cell will recognize the patient cells as foreign. This is not me, and it will start to kill it. This is what graft versus host disease is. When the donor immune cells recognize the patient as foreign and start to kill it. What is the other possibility? The other possibility is the recipient other cells or immune cells recognize the donor T cells as foreign and kill it. And what is this is graft failure or graft rejection. So get out of my body, I don't want you. And that's why it is very important to type the patient and the donor and to find a match donor. So none of these two scenarios can happen. What we meant by HLA, HLA is found in chromosome 6. Another tip, this is in the questions. And here you have class 1 and class 2. Class 1 are A, B, and C. Class 2 usually are 2 letters, DB, DQ, DR. So 2 letters start with a D. So if you have a patient who is matched in the red here in A, B, and DR, this is mean they are matching in 6 out of 6. So 1, 2, 3, 4, 5, 6. So this is 6 out of 6 match. We usually don't use that. We use either 10 out of 10 or 12 that they are matched in the whole 6 region. Why it is very important again, with here we talk about the source of or the donor source. So you have either synergistic, which is the best, that is your identical twin. And then the next is the match sibling, if you have a match brother or sister. And then the match unrelated donor is the next best. And then the mismatch related or unrelated donor. And then lastly, the mismatch related, which is the haploidentical transplant. When you go down on this column here, you go, the risk of GVHD and graft rejection increase. Again, there is nowadays ways to reduce the risk of graft versus host disease and graft versus rejection, the risk of rejection, even if you have a haplo transplant or a mismatch transplant. But the best match you got, the lower risk of graft versus host disease and rejection. So after you found the donor, then you go next to pre-transplant testing for the recipient and the donor. And what are those testing? So generally, they are extensive infectious disease testing to make sure that the patient has no infection that they can threaten their life. And also the donor has no infection you are going to give to the patient. You look at their eyes, you look at their ears, you look at their teeth, your pulmonary function test, their heart with echo and EKG, you look at their kidney, you look at their liver, and you also evaluate their disease, whether it's sickle cell or thalassemia or leukemia, meaning that to see how severe is their disease at the time of transplant. After that, you admit the patient and you give them conditioning regimen. What is conditioning regimen? Conditioning regimen is a recipe, just like if you're cooking something. So it is conditioning is a combination of therapy that is given prior to transplant or stem cell infusion. The purpose, the reason we give this conditioning therapy, it's either to immune suppress that prevent rejection, myeloablation, making space for the graft, or eliminate abnormal or malignant cells. What is myeloablative? Myeloablative is cytotoxic. Non-myeloablative conditioning is immune suppression. Other name for it is reduced intensity conditioning. After that, you infuse the stem cells in day 0. So you get the bone marrow procedure, the bone marrow harvest. Usually it's done in the OR where you insert a needle in the bone multiple times to collect the stem cells, make sure the stem cell looks fine and there is no debris or any contamination on them. And after that, you infuse it. And what it looks like just a blood transfusion. So for the patient, that's it. This is all the transplant. Um, for the other healthcare workers, nurses, doctors, what do I do? What do I need to know? So two things you need to know. If it is a fresh product, a product that you took at the same day of transplant, this is what the meaning of fresh product. Usually, the side effects are the normal transfusion reaction. If it was stored, usually we store it, we get the product, a chemical called DMSO, which stands for dimethyl fluoxide. This DMSO, the function of it is to preserve the product for longer time. But this chemical had side effect. One of the side effects is facial flushing, tickling sensation in the throat. It has very strong smell when you are in the room with the patient. Everybody smell it different, but there is rare side effect like bradycardia, abdominal pain, encephalopathy, or renal failure. There is ways to prevent the side effect from happening, either by decreasing the amount of DMSO or by increasing the hydration of fluids. After that, you count the days and you wait. So here you have day minus, which is the day of conditioning. Day 0 is the day of infusion, and then day plus are after you infused. So during this time, you have other side effects that might happen. So for example, during conditioning, mucositis might happen. After the infusion, something called sinusoidal obstructive syndrome or VOD might happen. Breast graft versus host disease, infection. And this here just represent the timing. So you get the harvest and infusion, you wait at 1 month, engraftment, and each one of these has a definition. You keep the immune suppression and you taper it by 1 year, and you count your survival as a center. This is another way of looking at the same picture, whether it's autologous or allogeneic transplant with the timeline. After that is a waiting game. So hospitalization, usually the patient is staying in the hospital till they are engraft. Engraft mean absolute neutrophil count, which is ANC, more than 500 for 3 consecutive days. Usually take 14 days if you get the source from peripheral blood, to 30 days if you get the source from umbilical cord. But that is just a general range of when the engraftment happen. Transplant restriction, there is restriction of the transplant. Again, before the era of COVID, but now this restriction for everybody. And then you wait for what we call immune recovery. So usually, and this is another question on the test, neutrophil engraft first, platelets second, and then hemoglobin. T cell reconstitution, meaning that T cell function takes up to 1 year after that. What is the killer during this immune recovery? Usually it's bacterial infection, usually in the first 180 days. Fungus, it's just during the initial transplant, usually related to leukemia, and then viruses like CMV, adenovirus, EBV, HHV6, and just name it. So what is the management for fever? If your patient had a fever after transplant or during conditioning, you do a thorough examination, physical examination. You look at the perineal skin, you look at the lion side. We usually do non-invasive exam, meaning that no rectal examination or something like that. You culture all the lines and peripheral. You get a chest X-ray if the patient had respiratory symptoms. You get a nasal swab for viruses if the patient had a URI or upper respiratory infection symptoms or sign. If the ANC is still less than 500, you give either cefabime, ceftalas, zosine, whatever is available in your center. You add vancomycin if the patient had mucositis or evidence of gram-positive infection. You consider giving or increasing antifungal if the fever persists despite antibiotics and culture negative. If the culture is positive, then you know your bacteria and you treat it appropriately. Usually the patient is stay on antibiotic till they engraft. Sorry, guys, I have to take this. Sorry again. I have to take this. I had to take this. What is the infection post-transplant? So you have phase 1, which you might have graft versus host disease, and then you might get infection. So you have graft versus host disease or infection. This time, the neutropenia is the risk factor because neutropenia make a barrier, and then you have a central line. So the main killer in bacteria is gram-negative or gram-positive. Which is, and you have the gastrointestinal species, and then the encapsulated bacteria is usually happen late. You don't have to memorize this. This is just an information if you need it. So blood pressure management. If the blood pressure is high, you repeat it again in 15 minutes. After 15 minutes, if it's still high, you give some fast-acting medication, so nifedipine, hydralazine, whatever is available. And then you transfuse platelets if platelets are low with high blood pressure because the risk of stroke and breast is high at that time. If your blood pressure is low, you give fluids and you think about why it is low. Is it infection? Is it from chemo? Is it from hydration status? If your patient need an oxygen, you examine the patient again. You consider getting a venous blood gas and a chest X-ray. You think about the etiology. What is the reason this patient need an oxygen? It could be mucositis that's blocked if the kid is very small, the airway is small, and if they have mucositis, that might be the reason of the oxygen need. You think about volume overload or capillary leak. You think about infection. Think about intrinsic lung disease and very rare side effect from transplant, which is called diffuse alveolar hemorrhage, and you check the platelets. Volume management. Weight is very important for the patient. We often need to weigh the patient twice a day and trend it, meaning that look at their weight in the morning and evening, yesterday and today. You count and restrict ins and out, whatever the patient is taking and what comes out. You look at the urine output in cc per kg per day. You look at their electrolyte status, and you think about whether this volume is intravascular or extravascular fluids. But the most important thing is weight, and often it's needed PID. Other side effect or other complication from transplant, what we call PRES, which stands for posterior reversible encephalopathy syndrome, typically in a setting of hypertension for 70 to 80% of the patient. Usually it comes with headaches, vision change, seizures, altered mental status. It is usually in a setting of calcineurin inhibitor, so your cyclosporin. It can be seen in other oncology patients with other medication, but in transplant, mainly it's because of the cyclosporin. How do you manage PRES? So if the patient is having seizures, you stop the seizure first, you treat the seizure first. But if the patient had high blood pressure, you control the blood pressure. If the patient platelets are low, you transfuse platelets. You check magnesium, because for the most part in breast syndrome, it might be low and you give magnesium if it is low. Graft versus host disease. It's another complication from transplant. So it is an immune attack of the graft, the donor cells, attacking the recipient or the patient. System involved for acute graft versus host disease is usually skin, by skin rash, GI, have a lot of nausea, vomiting, and diarrhea. It is usually worse if you have a mismatched donor. Acute usually happen when it is less than 100 days. Chronic, if it is more than 100 days. The chronic is different process. It has longer treatment. It is more like diffuse inflammatory process like scleroderma or lupus-like syndrome. Prevention of graft versus host disease is the best. So you keep your cyclosporine, the calcineurin inhibitor, in goal defined by the team. You ensure that the patient is taking the medication all the time. And this is type of skin rash that can happen with graft versus host disease. Usually it is involve the soles and the palms of the patient, usually are red and angry. What is the treatment for graft versus host disease? The front line, the first line of treatment is steroids. Treatment usually is 1 to 2 weeks after resolution, and then you do tapering of the steroids for a longer time. If it's steroid refractory, meaning that the steroid cannot fix it, there is multiple other agents, but there is no second line. Nobody agrees on what the second line is, but there is other agent can be used. What is the late effect? The main late effect is infertility. The condition in chemo can kill the rapidly growing cells, including the gonadal cells. Delayed puberty in female, impaired growth and development, especially if you are using total body radiation. Second, malignancy, especially if you are using TPI again. Intellectual impairment, or because if you have a CNS-directed therapy, meaning that in leukemia, you are treating the CNS whether with radiation or intrathecal chemotherapy. In other countries, there is other concerns. So malaria is one of them. In some countries, tuberculosis, typhoid, and so on and so on. So the other thing is talking about the cost. Cost is an important risk factor, meaning that if you have no access to transplant and you have a disease needing transplant, that is a big, significant mortality for transplant. Other things that might also contribute to the cost and complexity of the transplant, the hospital infection control, the source of stem cells, drugs, and the patient age and the patient disease too. I stole this slide from Lawrence. Prognosis depend on the disease, donor availability, previous and existing toxicity. So if you have a sibling match transplant for aplastic anemia, the survival rate is more than 80%. Multiple relapse AML, for example, and you do transplant, the survival rate is less than 20%. For most disease, overall is 50 to 60. But remember, 100% die without transplant. General limitation, the one limitation is transplant-related mortality. We usually tell the patient there is 10% chance of dying during transplant. Donor availability, graft rejection, but it is not as common as it used to be. Graft versus host disease. These are all general limitations for transplant. And with that, this is my last slide, and good luck and welcome. I welcome any question if you have some. Any question, guys?
Anybody has any question? So I think they don't have any questions. So just I have one question. Sir, is it I'm audible?
What did you say? I didn't hear you.
I have one question. Actually, like in the stem cell storage, you told that like cryopreservation stem cell and the fresh stem cell. So generally, when we collect the stem cell PBSC, the previous day we'll collect the PBSC collection, and we will store in the normal refrigerator blood product where we store in the 4 to 8 degree refrigerator we store, and next day morning we'll give the stem cells. So how long we can store without cryopreservation the stem cells?
that is considered a fresh blood. So usually we do the cryopreservation if you are giving the stem cells in a week or so. But if you have a system where you can store them for a couple of days where there is no risk of infection in a normal refrigerator, then you don't need the DMSO. So if you don't need the DMSO, it's still considered a fresh product. So
Okay.
here too, we collect it the day before and we give it the day after.
Yes. Yes.
When I said cryopreserve, I meant that when you preserve it in -80 or -70 degree
Yes,
freezer.
Yes, I got it. Any of the nurses, do you have any question?
I know this is a lot because again, every one slide of what I presented today is a lecture by itself. And during the next couple of months, you are going to hear about all of these: fever management, central line, conditioning therapy, HLA matching, and all of what I presented today. Today is just introduction. Okay. If there is no question, and then the floor is yours, Sandeep, to administer
sir.
the poll question.
Thank you, sir. The session was very good and it was very understandable for all the nurses. Dr. Faulkner, can I start the polls?
Yeah, please do, Sandeep. I'm here to help you if you need, but go
I will.
ahead. Yes.
Okay, so for all the nurses, like I'm going to start the poll now. You have 10 questions related to the presentation, what you heard. So, sir, shall we give the 5 minutes of time or 10 minutes, sir?
Yeah, 10 to 15 minutes.
Okay. So I'm going to start now. Can everyone see the poll?
I can see
Yes.
it, but I don't know about the others.
I can see it,
I-
Sandeep. Yes.
I can see that. Yes.
I can see it as well. Thank you.
Ali is the new baby. Oh, so nice.
Very cute.
Congratulations.
Yes, Ali. Put it closer. We don't see. It's a she, right? It's a girl. Yes.
Yeah,
Oh my God.
so nice.
Boy. Yeah. I had my share. It's nice, but boy,
Mm.
not the work.
Yes, no, definitely. She looks tiny. I think she's
She's 1 month old.
oh, 1 month. Wow.
Yeah.
So you're still having you're
Yes.
awake all night and sleeping during the day.
Yep. We sleep whenever she sleep. We wake up whenever she wakes up. Doesn't
Yeah,
matter, day or night. But she's
exactly.
happy. She's very happy.
She's
She's not.
breastfed.
Yes. Yes.
Okay. So lucky you.
Yep.
Yeah.
I have the diaper duty.
Okay. Very well.
Right?
Oh, she's saying something.
Yes, we're talking
Okay.
about you. Sorry.
So I have to leave. We will talk soon in the next meeting. Okay.
Okay. Thank you, Eugenia.
Thank you, Ali. Bye.
Bye.
Thank you,
Bye.
everybody.
Bye.
Thank you, ma'am. Thank you.
And I have to leave too. So Sandeep will have the poll and the answer, and we'll look at them and we can talk about them next time.
Okay, sir. Thank you,
Thank
sir.
you, Ali. Very nice lecture. Thanks a
You're
lot.
welcome. Oh, you're welcome
Thank
anytime.
you.
Anytime.
Okay.
Thank you.
Bye-bye.
Bye.
Okay, is it all the nurses completed? Anybody is pending?
You should be able to see the number of people that complete the test, Sandeep. In any case,
It's showing 70%,
normally-
sir.
oh.
Is there anybody is pending?
Normally 30 seconds per question is enough.
Yes, yes, sir.
When I used to give these polls, I normally would give 5 minutes.
Yes, sir. Now almost we finished 10 minutes. Can I stop?
I think after 10 minutes you can stop. I think if people didn't answer, maybe they don't want to answer the tests. Do you know? Can you see how many people answered?
21.
You should be able to see.
21 out of 27.
Oh, that's okay. I mean, yeah, there will be a few people that maybe don't want to take the test.
Okay, sir. I'm going to end the part.
Unless there is somebody who still has to answer, please let us know. If nobody wants more time, then I guess we can end it, Sandeep. Then
Okay.
you will receive. The Zoom needs a little time, but you will be able to download these Excel files with the test results. Let me know
Okay.
if you have any problems.
Okay, sir. Okay.
I can help you out then.
Okay.
Okay. Well, I guess that's it. Thanks a lot, everybody. Thank you, Sandeep. And
Thank you, sir.
let me know. Yeah. Okay. Bye-bye.
Thank you, sir.
Thank you.
Thank you. Bye-bye.
Thank you, sir.